You're listening to the podcast between doctors and friends. Hello to another episode of Doctors and Friends. No, between Doctors and Friends. And here goes the laughter. I did not introduce anyone last week, and so I will continue and not introduce anyone this week. How was your week, Dr. Ray?
My week was better than the last week, so I'll say that. So just a little bit more steady this week, I think. I'm dealing with a family member who has a health issue, and so that's a little bit more stable, and so that made the week a little less stressful than the previous week. And patient-wise, I don't think I had any big issue come up. As far as patient goes, I had a pretty slow week as far as deliveries went, so that was kind of nice to just, reset and everything. But otherwise, yeah, pretty good week.
Pretty good chill week. And Dr. Foz?
Nothing exciting to share, unfortunately. Or fortunately. Probably fortunately. Same old thing. Wait, I have to ask though. Yeah. So, Dr. Ray, how many deliveries do you do in an average week?
I don't know. I would say maybe 5. 5 a week would be average. So yeah, maybe about 15 to 20 a month. But this week I only did 1, so that was very nice to just not have to worry about what was happening at the hospital. I could just focus a little bit more on the office and on my personal life and not have to, rush back and forth to the hospital or worry about what was going on in the hospital. So that was a little bit nicer, but I would say maybe 5 a week I do.
Wow.
Yeah, I've always thought that must be really hard. Like if it's during work day, you're like managing a delivery while you're doing other stuff.
Yeah. So often.
I mean, that's like the worst kind of multitasking.
Yeah. Yeah. So the patients will be they come into the hospital and, we'll get a call that the patient showed up to the hospital and that now she needs to be admitted. And while she's, being admitted and she's laboring and she's progressing with her dilation, I'm not there in the hospital. I keep tabs on everything. We have, an app on the phone that we can log into and see everything, including her fetal heart tracing. I can look at it from my computer, and then, every 2 hours or so, the nurse will call me or I'll call the nurse for an update. But I'm seeing my patients in the office, so managing the patients and then getting the phone calls from the hospitals, and then when it's time for delivery, running across the street or driving over to the hospital to deliver the baby, and then driving back to the office to finish up my office. So it can be very stressful if I have a few in labor or it's a very busy day. So I do definitely appreciate the days when I don't have anybody in labor and I can just concentrate on my office patients.
Dr. Ray, have you ever considered using one of those e-scooters to go from your clinic to the hospital?
Well, one of them is like, like an 8-mile drive or so. So that would not make sense at all because I can get there much faster in my car. The other one is just across the street. So maybe the e-scooter would save a minute, maybe I think just a minute, 2 minutes at the most. But then it's the issue of, okay, now I'm in the hospital with this e-scooter. Where do I leave it?
Just leave it on the sidewalk.
Yeah, I don't know quite how they work. I don't know if you need a key for them or a code or something, but I don't know if I would feel comfortable just leaving it like outside the hospital. Wouldn't someone just take it?
I think your hospital needs to have like all those birds because you can just leave it in the side. Let the next doctor grab it.
You mean like the Lime scooters? Like that
those Lime scooters,
Yeah.
Yeah. But most doctors are in the hospital. They don't need to go back and forth. I think OB is probably one of the few that do go back and forth, and not every OB has an office that's close enough to scooter to, so they would drive to.
Because That would be badass, seeing a doctor in their white coat. In their white coat.
Yeah, I think, I'm in a suburban area, so I think maybe if I was in like New York City, and had my office, right there in New York City and trying to get to one of their hospitals, then a scooter might be probably more reasonable. Or, I don't know, like big cities like Boston, Chicago, like if I was in a city setting, but I think in a suburban setting, it's a little bit different with the scooters.
So I mentioned your white coat lab. Tell us more about these things. Like, do you guys get one every year?
The white coat?
Yeah.
Depends on where you work.
I haven't worn a white coat in like 25 years.
Really?
I don't wear a white coat. Yeah. They're uncomfortable and they're not necessary unless you are maybe in like a academic institution or a very formalized institution where they wear them. But I would say people in my field, OB-GYN, I never see any of us wearing them at all. I'll occasionally see maybe some of the internal medicine doctors or the surgeons wearing them, but for the most part, they never wear them.
Wow.
Yeah, you're in maybe a different kind of institution.
Yeah. Well, currently I do not. But until recently I did. And you know why? Because I need the pockets. I got to put my stethoscope. I got to put my like lip gloss in there. Got to put my mobile phone. Like I need pockets. That's like the biggest thing.
Come to think of it, I'm thinking of the Pitt. Some of them wear white coats, like the mom, the surgeon mom. She came down and she was wearing a white coat.
Yeah.
Right.
Yeah, I would say like in academic institutions, they probably do wear their white coats more because they need to decipher between students, residents, attendings, ancillary staff. So I think in those situations they would, but I don't work in a facility like that. So it's a lot different. And so I rarely see doctors in white coats.
I am gagged. And to hear that a lot of doctors find them uncomfortable.
Yeah.
Wow.
They're so uncomfortable.
It depends, seriously, so it really does depend on a lot of regional things. Like, I remember when I don't know if this is true or not, I remember when I was looking for a residency, there were stories of people who were going into residencies like on opposite coasts and, faraway places. And they're like, yeah, they think it's unprofessional to wear a white coat, which I think was funny. And that the residents had to, like, when you were post call and you're presenting your patients the next morning. So that for those who don't know what that means. So you're up all night in the hospital admitting patients to the hospital. So like somebody comes into the hospital with like chest pain or gastrointestinal bleeding or something. And the ER does their assessment and says, okay, this person is too sick to go home. They need to be coming to the hospital. So then they call a consult with, like the hospitalist, whoever's doing the admissions to the hospital. And that would be me. And then come down, assess the patient. Yes, they're having a heart attack, cardiology involved. This is what we're going to do. This is where they're going to go. They're admitted to the hospital. So if you're doing that all night, in the morning, you have to then present those patients to your team. So that would be your attending physician, your co-residents and interns and medical students and whoever else is there, right? And it's like a speech you give, basically. So-and-so is a 57-year-old male who started having chest pain at 4:00 and, was presented at 7:00 with crushing substernal chest pain radiating to their shoulder. EKG showed this, blah, 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 showed this. Blah, blah, and it's the whole history of the patient. So then everybody can talk about what they're going to do about the patient, So you're doing that after you've been on your feet for more than 24 hours. So you're not like in the best of shape. So usually, we would wear scrubs. And even though you're not a surgical service, we would wear scrubs and whatever. And you go through your day and then you can finally go home that night. I had heard stories of like in other places, like the residents, when you were post call, so you were, you'd admitted your patients and now you're getting ready to round with your team, that they had to go like get dressed up. They had to put on suits and ties, pantyhose and skirts and all that stuff. And I remember thinking, that's insanity. Like, I'm just trying to find time to brush my teeth, like much less just like worrying about how that looks.
Oh my
And
gosh.
I know it, but I don't know. I don't know if that's rumors, gossip, and hearsay. I'm sure there's certain regional things where, in terms of white coats, there's large variations of where you live, where you practice, the nature of your practice. I've had places where I had to buy my own, or I would buy my own. I've had places where they gave them to me. I've had places tell me you're expected to wear it. I've had places tell me that we don't care if you wear it. Like, it's just, there's no consensus nowadays. You know what I think it has a lot to do too with this? It's kind of like the the rise of casual dress in the business place, you know, like looking at like people like Zuckerberg and his hoodies and jeans and stuff. And so it's kind of, I think, trickled over everywhere. I've worked with colleagues who wear scrubs every day to work, and that's just what they wear. And I kind of miss that. Like, I wish I could do that, because you don't have to think about what you're wearing. You know?
Well,
I see a hand raised.
Yeah, as a patient, and let's say I'm in, like in a room, how will I know if the person's coming in is really the doctor or someone who just pretends to be one?
Everybody should be introducing themselves to you. You know, you walk in and your front desk is wearing a name tag, and the name tag says, like, Susie or Jimmy or whatever their name is. And then, they walk in, hi, welcome in. I'm Vanessa. How can I help you? Or whatever their name is, and then the medical assistant should take them back and be like, hey, hi, I'm Mary. I'm the medical assistant. Come with me. Let me get you roomed, and then when I walk in, I'm like, hi, I'm Dr. Foz, if I don't know them.
You guys have to carry IDs? Like, how will I know if you're the real doctor?
I mean, I wear my ID badge, so.
Okay.
Depends. Yeah. I mean, where I had been previously, there wasn't any requirements to that, but it was embroidered on my jacket. Like, my name was embroidered on the jacket. Like,
can we QR code you and go, oh, okay, that's the real doctor?
I mean, then we come in and I mean, I always come in and introduce myself.
Okay.
Yeah. I always tell them who I am.
I mean, it's a small enough office that, I wouldn't think that they would have anybody be able to be fake walk in.
Yeah, so I'm coming from like the Dateline, mine's like.
Well, I've also deliberately and have glad that I've worked in kind of smaller places for the most part. So it was a little bit more like there wasn't like badging in that had to happen because it wasn't a big deal. Like, it's just, small places. So, but I mean, when you work in hospitals and bigger institutions, like, you have to wear a specific ID badge that's got, your name, your employee ID, your job title, and that can get you into more secured areas of certain places.
Wow.
Like, you can't just like walk into the intensive care unit in a lot of hospitals. You can't just like stroll in like, hi, I'm here to see so-and-so. I mean, you have to be admitted because those patients are pretty fragile, and there may be, infectious disease concerns and safety concerns and all kinds of stuff.
Well, like in the maternity ward, I noticed that it's a lot of security there. Dr. A, can you talk about that?
Well, we have locked doors that you have to use your ID badge to get into, or you get buzzed into. So that's the only security really that we have. And then, when you're coming into the hospital, you enter through, whatever entrance it is. There's usually a security guard there, and you have to tell them, what patient you're coming to see and where you're going. And then when you get up to the maternity ward, they have to buzz you in. So that's the basic security that we have. Yeah.
Is it like to prevent patients from like stealing other babies? Or am I again coming from the Dateline mindset?
I mean, there has always been a concern about people stealing babies, whether it's patients or it's, other people that are there to take them. So the babies have little monitors that are put on them, like a little an alarm monitor that is put onto their ankle, so that if they go past a certain point, then the alarm will go off. So kind of like a baby alarm or a low jack or one of those types of things. So that the babies can't be taken past their out of the ward. And so when the babies are discharged, then those are removed.
Wow. Yeah. It's like, does it alarm like in the grocery stores?
Yeah, just like when you're leaving the store and you have that little thing that's, stuck to your shirt and it goes, the same thing. So if they go past a certain point, where they shouldn't be leaving or the baby shouldn't be going off the maternity ward, then it'll alarm. And then it automatically
they have like codes for that and everything.
Yeah.
Like I remember we had like
codes. Yeah.
And that was just basically mean there's a baby kidnapping, doors get locked down, like everybody. It's bananas. What a sick world we live in.
Yeah.
Yeah, I know someone who gave birth at Cedars-Sinai, I think around the time, maybe a week, just a few days later, or maybe a week around supposedly when Beyonce gave birth.
Mm-hmm.
And they had all these like security and, like, so how does that work? Like someone like Beyonce, can they shut down the floor? I mean,
they did. They shut down the whole floor with Beyonce's birth.
If you got enough money, you can make anything happen.
But what happened to the other patients? It's like giving birth.
Well, they would just shut down a certain area. They're not going to shut down the whole hospital, right? Because they can't do that. So they'll just shut down a ward or a wing, and only, they'll not put any patients in that wing. So say in that wing, it's normally like 10 rooms, and they gave, one is to Beyonce. They just wouldn't put patients in those other 9 rooms. They would find other rooms for them.
Wow. So, okay, take us into that, now we're just, just pretending like, you weren't there and I wasn't there. But
oh my God,
what happens? Like, you guys, how does that kind of shake up your workflow?
It doesn't really. I mean, hospitals that cater to these wealthy celebrities, like Cedars-Sinai, probably have, certain wings built into the hospital that this is like you can only go down this wing for one room, and this one room will be given to whatever celebrity or high paying client they have, and that's their whole side of it. So, these hospitals that, like I said, cater to them, like my hospital, nobody would show up at my hospital unless they were driving by and had an emergency. No celebrity or multimillionaire is delivering at my hospital. So we don't have sort of a setup like that. But these hospitals, probably a lot in New York City, probably, USC, UCLA, Cedars-Sinai, some of these. I think in LA, it's really just Cedars-Sinai that all the celebrities go to deliver. So I'm 100% sure that they have built probably on their top floor several private access suites and private access rooms for not only, the people having babies, but also, the celebrities who are dehydrated or having heart attacks or have had their surgeries or whatever it is, so that there's probably, their private security at the entranceway, and only certain people can go in and out of that suite. So it's just because Cedars caters to these high income, high status people, they have, adapted the way that they do it. So all the regular people who show up at Cedars to have their regular babies, they are probably on a different wing. And so the regular doctors who don't take care of the celebrity, patients are not impacted by it whatsoever. You just can't go to a certain area.
Yeah, I'm sure there's like contingency plans, like contingency things, like, these are things that happen here frequently, so this is how we handle it in this manner,
Yeah.
And do the do the babies stay together with all the other babies, or do they really seclude
No, for like the last, I don't know, 15, 20 years, the babies stay with the moms in the room. So they do rooming in. So there's no big nursery full of babies anymore like they show on TV. The babies stay in the room with the mom the whole time. So, yeah. So unless
I've never worked in a hospital where I've seen like a big nursery of babies too. It's always been like rooming in.
What?
Yeah, the babies stay with the mom. The babies never, they never leave the room. I mean, unless the baby is sick and has to go to the NICU, Or we do have a nursery still, but our nursery is meant more for, like if the mom can't watch the baby during that time,
right,
or
if the
baby needs to, like if the mom is going back to surgery, then they'll put the baby, in the nursery for a while if nobody is there to watch it. And then, or if the baby maybe has, like needs some blood tests or something to be done and it's not quite sick enough to go to the NICU, then it'll stay in the nursery. But in our nursery, maybe we have 1 or 2 babies there at the most. Oftentimes it's empty, but maybe I'll see 1 or 2 babies in there at the most. But all babies are in the rooms with the mom, unless they're in the NICU.
Wow, the mom doesn't even get a break.
Mm-mm.
Well, the thing is they do though. There are nurses that'll come around and do things, and it isn't like they're completely like, here's your baby, figure it out,
Yeah, they'll come and help, but it's your baby and you're supposed to take care of it. So that's the philosophy now is, the baby is supposed to be with you. You're supposed to bond with the baby. You're supposed to learn to take care of the baby, and the baby's crying. The baby needs to be fed or changed. So nurses don't come in and do that anymore. That's the parent's responsibility.
Wow. And you guys send the mom home the following day, or what's the typical?
They need to stay minimum 24 hours. And so after 24 hours, they could go home, but they can stay up to 48 hours for a vaginal delivery. Or if it's a cesarean, they can stay up to 4 days.
Wow. That is wild.
And it's been this way for almost 2 decades now. They've been in there with the mom. Like, where was I? Watching TV. That's where I was.
Avoiding kids.
Let's see, 20. Yeah, I had mine in 2004, 5, and they were roomed in with me. So that's 20 plus years. Yeah. So at least that long.
There's no like glasses, like a Zoom to watch all the babies.
No. They're, like I said, they still have the nursery, but those babies that are in the nursery are there for, some reason. Like, but they're there usually temporarily.
They're there to be babysat.
Yeah. Yeah. But now they're, in the rooms with the moms. When I had my son, he was jaundiced and he had to go to the nursery to be under those Billy lights. But now, I don't know, maybe the last 10 or 12 years, they've now put those Billy lights in the room with the patients. And so so the baby doesn't even have to leave the room to get, if they're jaundiced, to go under those special lights. So the babies really are meant to be with the mom and dad for the entire stay, unless the baby needs extra level care. So yeah, those scenes in the movies, they make great scenes because it's always, somebody walking up to the window, seeing the rows of babies and, being told, that's your baby or which baby's yours or whatever it is for the scene of the movie. But that doesn't happen anymore. There's no rows and rows of babies and everything.
That's like
babies are with
pre-1990s maybe.
Yeah.
Like, it's an old-fashioned way of doing it. I think they used to do that in like the 50s, 60s, 70s, probably up into the 80s kind of thing.
Yeah.
But,
All right. Well, now I'm just really revealing my age.
No, and I have to say, like, this is how like, a lot of these movies or TV shows aren't really consulting people who work in these spaces, because even when you look at shows today, it's still portrayed as if, like, that's what happens when it comes to, like, you can just walk up, oh, look at the beautiful babies all in a row, and I'm just gagged right now.
No. The babies stay with the moms, because,
it's better for everybody.
They want the bonding time. They want to be able to breastfeed on demand. They want, the safety. People don't want to let their babies go. So for the most part, they stay right with them. 100%
and all the stories
time.
on like baby mix-ups. Remember that whole thing? Like, oh, sent home with the wrong baby. Oh my God.
Yeah. No, it's 100%.
Now they're born, they're labeled.
But to answer your question, they absolutely do not consult the right people when they're making these TV shows, and they absolutely never ever consult OBs, because every single pregnancy scenario and scene on 99% of every show I've watched is 100% wrong. It's awful.
So
they never ever
all the writers
get
out
the OB
there,
right. They
come
never
to
do.
listen to this podcast.
Yeah.
Well, but
I
see,
will
if
be Dr.
you
Ray's agent.
but if you make it real, it's not. I mean, it's you have all these scenes where you have people standing in front of the big glass window looking into all the babies, and and they have to have their little scene. I mean, if they're roomed in with mom, you don't have that. It's artistic license.
Yeah,
too,
exactly.
so,
Yeah, no,
okay.
it's 100%.
It's not always real.
They
It's
have
okay,
to make it more dramatic, and it's ridiculous of how dramatic they're making it. And yeah, I often am pulling out my hair watching some of this stuff. Going,
it is,
so
but
ridiculous.
I also think Iron Man is also not real. So
right,
it's all
right. So
wait, Iron Man's not real? Kidding.
Well, with my little steamer, I could be steamer woman. Dr. Ray, I'm just kind of a little bit obsessed with this. Did you finish the Pitt over the weekend?
I did.
Okay, so there was a scene, and for anyone that's listening, of a pregnant woman, and does that happen often? Like, can you talk about it a little bit more? Because I can't.
Which
the
scene are you talking
woman,
about? Was the pregnant woman who came in and had the seizure, and they had to deliver the baby right away?
Yes.
That one?
She's like, she's fine, but and all of a sudden, I mean,
that's
would understand you more than I would.
Yeah, that's pregnancy-induced hypertension, preeclampsia, eclampsia, whatever you want to call it, is a very serious and potentially dangerous and deadly issue. And I think it was portrayed fine as far as the diagnosis and the science and everything goes. And yes, those women can have seizures right away. And I think all of the medications that they gave and everything, that was appropriate. It's very rare to have them have, the cardiac issues that patient did, where they go into cardiac arrest, but it's not impossible. Pregnant women are, just as much a risk as other people, like to getting into accidents and having, issues happen to them. So the problem, the issue that I have is not so much like how they portrayed the medicine and them doing the delivery and them getting the baby out and all of that. It's more so that the OB doctor is never around. They're always calling for an OB doctor. An OB doctor never shows up, and it has to be the brave, dramatic ER doctor who kind of saves the day and delivers this really difficult, pregnancy or problem that they have. And they always portray the OB doctor walking in after it's all done and kind of, ticked off like, what are you doing here? What's happening here? Or, oh, I was busy doing something else. All right. And so that I don't like, because that is very unreal. Like, this patient would not have even gone to the emergency room. They go straight to labor and delivery. Any pregnant woman that's, over 20 weeks, they go straight to labor and delivery. So she should have been taken to labor and delivery. She would have been taken care of by the OB doctors up there. So it's just the portrayal. And even when they had that baby that got stuck in the first season, the shoulder dystocia, they're constantly calling for OB, and OB's just nowhere to be found, and they have to do all of everything themselves. So obviously it's a show about ER doctors. You want to make the ER doctor the hero. The OB doctor is just an afterthought of the things. Yeah. But it's very much not how it would work in the real world.
Yeah. No.
Yeah.
Great. Okay. I'm thinking about, like, in my experiences as non-OB and non-emergency room, but having spent a lot of time in both of those things, the only super pregnant women you see will be like trauma victims, like a 7-month pregnant woman is in a motor vehicle accident, then she's in the ER.
Yeah.
But like everybody else is like, if you're like deep into a pregnancy, off to labor and delivery you go, and none of us want to touch it with a.
But they always get the calls ahead of time of when they're bringing in a patient to the ER, right? So you see them always saying, an MVA is about to arrive. We're about to get a stroke. We're about to get whatever. So they know, what's coming. Very rarely do ambulances just pull up to the ER and they have no idea what's happening,
That's
so
true.
It's
not like a bus unloading.
Right. So they call ahead and, they're telling them, we're on our way with this situation so that you can be prepared. So usually they're going to say, we're on our way with a pregnant woman who was just in a car accident. And the person who's going to hang up the phone is going to immediately call OB, and OB is going to be down there almost waiting for the patient to come because, while the ER is doing their assessment on making sure that, the patient's conscious and she doesn't have broken bones and, whatnot, the OB doctors and the OB nurse, because the nurse always comes with us as well, are immediately going to, listen for that baby's heartbeat, make sure that that baby is good. They're going to put her immediately on a fetal monitor to watch that baby. And then if necessary, if the baby is unstable and they need to deliver that baby, then they will go ahead and do that. So at least for me and my hospital and all the hospitals I've worked at, we get calls that will say, OB trauma is coming to the ER, and we have a team that goes down there. We have a doctor who goes down there. We have like 2 or 3 nurses who go down there. They're ready and waiting for that patient to come. So it's always, to me, obviously I'm more sensitive because I'm OB, that the way that they portray us as like just never being around.
I know, always late, like busy with your podcast.
Exactly. Or they're doing something else. I mean, on this episode, the OB doctor came down and said, "Oh, I was busy dealing with twins that were septic." So yeah, there are other emergencies going on. The OB floor probably looks just like the ER. Yeah. With the amount of deliveries that they're doing at that facility, and they're probably going room to room delivering babies and handling, the emergencies that are up there. And so for maybe, they're not available to come down, but it's always just sort of like, where is the OB doctor? Why are you doing this?
Well, I'm going to switch gears a little bit. There was this news that came out this week about a surgeon who accidentally, and Auntie, you could help me here, removed someone's liver
when they went in for the spleen. To get the spleen removed.
Yeah, is that possible with a team?
No.
And the patient died.
Yeah. Well, you can't live without your liver, so they're going to die.
Yeah.
Yeah, I have no idea how that happened. And in a lot of doctor groups, they're also talking about how in the world did this happen, because you can't confuse the 2 organs. They're on different sides of the body. One is, 5 times the size of the other. So it's impossible to confuse
the blood
them.
flow. The way you remove stuff is you have to know the anatomy, right? Which arteries to clip and all that stuff. And so if you clearly didn't know that, if you were just
and then the staff in the OR helping, because I don't know, Dr. Paz, maybe when the timeouts came out, it wasn't during my residency. It's probably, I don't know, maybe early 2000s, something like that, where now we're required by JCO to do a timeout before any kind of procedure is done.
Wait, what's that?
The timeout states the patient's name, date of birth, and the procedure that's being done, any allergies that the patient might have, any the fire risk, and the anesthesia score. All of those things are put into a timeout. Okay. And so before you start cutting, the nurse will say, okay, timeout. We have, Jane Doe here having a repeat cesarean section. Her date of birth is this. The doctors are these people, and she's allergic to penicillin. And then we all say out loud, okay, agree. So that we can all agree that we're all here to do this procedure and know what we're doing. And then we go in and do the procedure.
It's like a team huddle before the actual procedure starts.
Yeah.
Okay.
And so they would have done that. They have to have done that, and announced that we're here for a splenectomy. So everybody in the room should have known we're here for a splenectomy. He had to have had an assistant surgeon, because it's a pretty extensive surgery. So there had to have been another physician there at least. And the scrub tech and the circulating nurse and all the whole OR team would have been watching him do this. And it's obviously very wrong. It's like saying, oh, I'm going to do a cesarean section and everybody's expecting me to deliver a baby, but then I'm in there, operating on her kidney and no one's saying anything.
Yeah.
So I fully don't understand, and the medical community fully does not understand how in the world this happened.
Can I also add that my co-host, who's a retired nurse, she told me in an offline conversation the same exact thing you're saying, Dr. Ray. She's saying, because she said if I was the nurse in that room, I would have spoken and say, "Hey, what's happening? This is not." Wow.
You're on the wrong side of the body, and what is
right? These are also. I would imagine this is done laparoscopically, and
it was.
So it's all on a video. Like the entire operating room is watching it on a screen. It's not like only the surgeon sees it. Like everybody sees it.
Yeah, and don't you guys don't they talk about it out loud, or am I just
only?
Time out. We have this person here.
Teaching.
Yeah, I mean,
or talk to your assistant surgeon.
Yeah, I mean, I'll talk to my assistant surgeon or something, but if I don't have an assistant surgeon there, then I'm often not talking about like what I'm doing. I'm just doing it. But the scrub tech has probably done more surgeries than I have, and they are in the OR, for their entire career.
Day in and day out.
They would know what this is. And oftentimes I've been in a surgery situation and maybe I asked for an instrument that may not have been the best one, and they said, "Hey, do you want to use this one instead?" And I'll be like, "Oh, yeah, let me use that one." They watch people do the surgeries all day long. And so they can see, what's going on, and they often predict what's happening and what I would need, and if there's more bleeding than usual or whatever it is. So I can't imagine them saying in a timeout, "We're here for a splenectomy," and then everybody sitting there watching them take out the liver and nobody saying anything. So I'm baffled by that. I'm absolutely baffled about how this could have happened.
Yeah, and if it was done open, like that would be once it came out, didn't anybody go, "Whoa, that doesn't look like it should"? Like
exactly
bigger.
Because a spleen is, like maybe I don't know, like the length of maybe like a hot dog or something, and the liver is 3 times that size. It's huge. So I don't know.
Costco hot dog or no?
I don't know. A regular hot dog.
So do you think it's?
I don't think it could be done laparoscopic. I mean, I don't do enough general surgery, but I don't think you can do it laparoscopically because you can't take out that large organ from those small incisions. So it had to have done open.
So do you think it's like reported incorrectly? Maybe it's the way it was reported.
No, sensationalized, and also, when there's attorneys that are involved, they're going to lob all kinds of accusations.
Oh.
Yeah. So I have no idea.
Good to know.
I have no idea how that happened.
And then, I would usually in modern times, even, I don't know, I'm not a surgeon and I have not set foot in an operating room in many years, and I hope to keep it that way, both as a patient and as an assistant. I don't, usually before there's something major like that, there's imaging that's done. So there's going to be a CT or an MRI report somewhere. I mean, you don't just take out major organs for whatever reason.
Wow.
Splenectomies, I'm just thinking, it's often because of things like ITP and like certain conditions that necessitate that being taken out. It's usually for immune reasons. Mm-hmm. So I can see maybe the spleen wouldn't have any pre-existing imaging done. But I'm thinking if you have a condition like that, at least some point somebody's looked at your spleen to be like, "Oh, something's funny looking," But ultimately, the argument too that there are people who have that, the inversus problem where you have all your organs on one side and switched around, that also wouldn't fly because it would still be weird, and there'd probably be evidence of that somewhere in that person's medical record,
That's wild. Well,
it would have come out, to have that come out on the operating table, unless it was like a true emergency situation, right? Then it's not as likely.
What a legal nightmare. We are going to switch gears. For the listeners out there, we're looking at my Instagram. Yes. For the two listeners, we're looking at my Instagram. So I kind of saved things for this podcast. The first thing I want to highlight is Study claims that eating ice cream can be a healthy food and may protect against heart disease. Dr. Foz, what do you say about this?
No.
Damn you.
Yeah.
Well, ice cream is without nutrients. There is calcium in it, right? But it doesn't mean that, it's loaded with sugar and it's loaded with saturated fats. There is a little bit of controversy on how bad dairy fat is for people, and that dairy fat may be a little bit different than other types of saturated fat, but until the American Heart Association changes its stance, I'm not going to support that either. But no, I can't say it's a health food. And then we're talking about, so then you can get into like or USDA kind of things, like what's the definition of ice cream, right? If it's frozen milk with some fruit in it, then that's not ice cream. But that wouldn't be necessarily directly unhealthy. Does that make sense?
Yeah.
Yeah, but it's not fun.
Yeah.
All right.
Makes perfect sense. Now, would you recommend maybe a frozen banana, frozen grapes, or something like that? For
people make nice cream with the frozen bananas and all that stuff. That's just a frozen banana, whatever. If you smush it up and throw in a few chocolate chips, it's not the end of the world. So, but no, I couldn't say that ice cream is a health. Why are they saying it's a health food?
All right,
you have to read it and then see where the study was done. So you always have to look who did the study and where was it done.
Okay, let's play this. Oh no, it's not a video. It's just ice cream and heart health. Here's what some research suggests. Some studies.
All right, so full fat dairy. So they're basically saying that you can have full fat dairy like ice cream to lower your risk of heart disease.
And that's what I was saying. Like I said, there's a little controversy on full fat dairy, but that's not a settled thing yet.
Yeah.
And then you can't forget the sugars that's in that too, and that's not good for you in any capacity.
Nah.
Sorry, I know. Who doesn't like ice cream, right?
I know, right? All right, next one. Let's go with this one. Kris Jenner's raging her $300,000 miracle makeover is already slipping. Okay, let's see if it's a video. Hold on.
It's coming out. She's not happy with her facelift. And I can't say I'm honestly surprised, because the facelift technique she had, which was a smash facelift, goes through that typical honeymoon phase where they look good, they feel good for about 6 to 9 months, and then they start seeing the rebound to their tissues in the mid-face and the jawline. And that is what distinguishes a deep plane facelift over this. And this has no disrespect to the facelift surgeon that performed it. But the deep plane facelift is going to release those ligaments. It's going to reposition them. It's going to give the longevity. The smash facelift takes a little strip of skin, it repositions it or pulls it a little bit, trims a little skin, and that's it. Which is why those ligaments that still have memory, they start to bounce back and they start to rebound on the results. Which is why deep plane facelift remains the facelift of choice for longevity and naturalness of results.
So that's on IG by Somenek MD. Let's go with Dr. Foz.
I have some peripheral dealings with the cosmetic kind of stuff, but I'm not a plastic surgeon. I couldn't comment. I think I did, it's interesting. I did meet somebody who admitted to a facelift this week, and I thought this person looked good. I was a little surprised when they admitted it, and then I started to assess the situation. I'm like, okay, that's why you look a little funny. But whoever did this person's facelift, actually, I think did a pretty decent job. But I think a lot of it truly, facial stuff like this, it's absolutely an art in addition to a science. It's absolutely an art. And so you do really want to find somebody who knows what they're doing. Outside of that, I couldn't tell you the difference between all those different things because I don't care.
So these facelifts really kind of expire and like.
Well, I assume what they mean by a deep plane facelift, right? So aging of the face is not just a skin thing. So people think of it as just the skin, right? The skin is just losing its collagen and it's sagging and it's got texture changes and all those things. And that's not really just what happens. There's also changes in the bone underneath the face. So kind of like the best way to think of this is think of in your head a picture a woman who's like 95 years old, right? What do you see? Like there's a lot of hollowing around the eyes, like the eye sockets look like they got really big, right? Think about the temples. They're kind of like caved in and all those things. And so those are not just fat and muscle loss changes. Those are also bony changes. The skull actually changes as well. And so that's why sometimes when you do certain cosmetic, and please take this all with a grain of salt, I'm not an expert, but that's why when you sometimes do things like a facelift, if it's not done correctly, like you've just pulled up loose skin, you haven't really restored youthful contour. Does that make sense? So you have to restore the contour. And so that's why sometimes people will put in like a cheek implant, or they'll follow it up with like facial fillers, or like, if you do a facelift, that might help with sagging and looseness, but that doesn't, that's why they sometimes will also do like fat transfers, like things like that, like transfer of fat. And then, like certain procedures afterwards to help improve textures of the skin, like texture and pigmentation issues and all those things. So you can have super tight skin, but if you have like crepiness or, like pigmentation issues and all those things, like those kind of betray age in a different way that's more subtle.
Wow. Okay. All right. So we're going to move on to the next one that I saved. Okay. This is more for Dr. Ray. Let's see this.
35-week bump update. This baby's a low. And you know what's crazy? It's like, how do you tell if I'm carrying high or low? And then I read that it's a myth. So, like, I don't really know. I have no idea. I drink fish. There you go. I drink water like a goldfish. Colostrum is in. I'm trying to decide if I want to collect it. Please let me know if you start collecting colostrum at the moment your boobs started leaking, because I can't decide. My back hurts. My BO has gone up and stank. And I'm just tired 24/7.
Really subjective.
It's actually crazy to me that next week I start going to the doctor weekly.
All right, this is from an IG 90 Day Fiancé breaking news.
I just can't get over.
I mean, she looks bigger than 35 weeks. So
really,
yeah. So yeah, she looks bigger than 35 weeks. So she's probably going to have a big baby, or she might have a lot of excess amniotic fluid around her as well. But usually the feeling of, carrying low or the baby dropping, that is more of a subjective feeling from the mom. She'll say that, it felt higher and then now it feels lower. Or sometimes they're like, they can't take their breaths as well because the baby is so high up, but then the baby shifts and then they're saying like, I can take deeper breaths now. It's easier to breathe for me. So it's usually more of a subjective thing. But she also looks like she's very apple-shaped, so she probably has a very big, large midsection, even non-pregnant. So a lot of that could be just regular subcutaneous fat that she carries.
Jeez. Is it true that when a pregnant woman has like a big stomach that it's typically a boy? And
no.
Oh, so that's a Filipino thing, so.
Probably, yeah.
Okay.
Yeah. Nothing to do with the sex of it, yeah.
Wow, you just
wives' tales.
And then how miserable. Now I know why I have no idea what the maternity wing is. All right. You guys ready for one more?
Great.
Can't
wait. Can't wait.
Let's see it. Okay, this is
Can't wait.
This is just a photo from a psychological account on IG. In a medical anomaly that sounds like a tabloid headline, a Hong Kong woman reportedly lost 10 years of memories after a bout of extreme straining due to severe constipation. Doctors believe the episode was likely caused by a rare condition called transient global amnesia, possibly triggered by intense training that reduce blood flow and oxygen to the brain. What the heck?
So she probably had like what's called a TIA, which is a transient ischemic attack, like a mini stroke. But yeah, that could be brought on by that, by severe Valsalva movement. Extreme pushing can probably, limit the oxygen and possibly cause that. I mean, that sounds reasonable. I don't know. What do you think, Dr. Foz?
So it probably wouldn't be a TIA because that would indicate she would have full recovery, and then I wouldn't consider this.
Well, it does say she had full recovery.
Oh, all I see is a headline that says loses 10 years of memories after she pooped with excessive.
Oh no, it says while her memory eventually returned after the hospital stay.
Oh, geez. Yeah. And then I don't know, I don't know what can trigger transient global amnesia, except, I mean that's pretty broad. But I will say that constipation is very common and also not. People don't pay attention to it. You should not be constipated. That's really bad for you.
Yeah.
Really? So, the dog agrees.
Don't be constipated.
So if you're constipated and let's say you're in the toilet and nothing's just coming out, just stop it. Go get some ice cream.
Well, I mean, managing constipation is kind of a complicated discussion, actually. But ultimately, I'm hoping that everybody's eating lots and lots of fiber so that they're not constipated.
Yeah, we may have to talk about that in a future episode. I mean, to lose your memory, to have this kind
brain damage of some sort. I would think that maybe she, that if somebody said that, I'd be like, oh, she probably had a berry aneurysm in her brain that ruptured and she had an intracranial bleed or something like that.
That's where I thought it was going. Yeah.
Yeah. That's what I would think. But how hard was she straining? Good God.
Well, let me read here the last paragraph. Doctors warn that excessive physical exertion can occasionally disrupt oxygen flow to the brain, providing that giving it your all can sometimes have unexpected costs. Wow.
You should not be having to give your all just to poop. I think we're missing the main thrust here.
Yeah, but when that happens, then that's kind of scary. So what would you recommend? Someone's constipated.
Well, I would recommend to understand that this is not a common thing. It's not like everybody who has constipation. So see, what I'm afraid of is, that one other person who might be listening to us talk about this is going to be like, oh, I had brain fog, and so I must have ruptured something when I pooped. Oh my God. No. But just don't be constipated. This would be, I would say, a rare circumstance.
Got it. So if they had lost 10 years of memories, how would they know it's 10 years?
Because it would probably be found on when you're.
They probably asked her, what do you remember? And she's
probably
like, well, I remember, going to, Paris, and they'd be like, oh, well, that was 10 years ago. Do you remember anything after? No. Okay.
Yeah. Or I had no idea I was living here. I thought I lived there, and I'd moved out of there 10 years ago or something like that.
Wow. So, any last words before we close this episode?
No.
Don't be constipated.
Yeah. Fiber, water.
Okay. What else?
I heard don't be constipated and consult real OBs when you're doing these TV shows, so you can get so you can come across real.
See,
that would be wonderful.
That's the problem. When you do that though, it's because what we do isn't actually as sexy as everybody thinks it is. That's the thing. That's the disconnect.
But see,
if you actually made it real, then everybody like, oh, that's dull.
Yeah, but because this is a show about ER doctors, you have to show them doing what they do and make them the heroes and move their story along, So, a lot of people are saying, back in the ER days when John Carter was a resident. He had a pregnant woman come in with a very similar situation, but that pregnant woman and that baby died because they weren't able to save them, right? So that's a very famous ER episode. And so now they're saying that this is a little bit of his Noah Wiley's redemption, that he now, as Dr. Robbie, has now saved this pregnant woman and saved this baby. So, he's the hero, right? Dr. Robbie's the hero. The OB doctor is not the hero. So what would have, it would have changed the whole story if they were in there and she started seizing and they're like, and the OB doctor walked in and then the OB doctor did the whole procedure the way that it would have been done. The ER people would have just been standing there watching, or they would have left the room to the next patient, and that wouldn't have been, their story to tell. So I understand it from the drama point of view, and that's why I watch it. It's the drama point of view, but, the whole thing, because they always make every pregnant woman that walks in is some disaster about to happen, and there is never an OB doctor around to be found. But so that's, again, I'm sensitive. It's my little pet peeve. But for the story arc, for Dr. Robbie's arc, he had to have done that. And then he leaves that scene. You see him being, very emotional of what he was able to do. And then he goes into the little baby Jane Doe's room.
Okay. No spoiler.
How have you not seen this? You're the one who asked me if I saw it.
Well, we have a lot of listeners out there that haven't seen it yet.
Okay, well then put a spoiler alert. Put a spoiler alert on that and just let them know. But anyway, so
power to the OB. Screw the ER doctor.
Exactly.
Well, as a mom, what are your thoughts about the mom who's a surgeon and her daughter is in, the conflict between the mother and the daughter, the pressure?
The mom that wants the daughter to be the surgeon, the body or whatever.
Yeah.
Oh, I think that's like every maybe parent wanting their child to, be a little version of themselves and take over, follow their footsteps, so to speak. So, I think that, I don't know. I think a lot of doctors nowadays would probably tell their children not to be doctors, to be quite honest with you.
Totally.
Yeah.
Wow.
And so if they chose to be a doctor, I think she's trying to get her to do, something that is, quote, worthy of her talents. And a surgeon is maybe like one of the top level doctors that you can be, and somebody who is very well respected and makes a good living. And so she's probably trying to encourage her to do something similar like that. Not that ER, isn't a very well respected field as well, but I think she's just probably telling her more to do, what she did. And maybe she's thinking, you can come work with me and you can take over my practice, sort of, so to speak.
Well, that blew me away that many doctors don't want their kids or may not encourage your kids to be doctors. That's interesting.
Yeah.
It's a lot of burnout.
I think majority of I'm probably going to say 75% of doctors would probably encourage their kids to not be a doctor. I think the general philosophy is if the child wants to do it and that's their own desire, then yes, we'll encourage them and support them. But no doctor would be there and say, hey, you need to grow up and be a doctor. You should be a doctor, and encourage and sort of, make them be a doctor, so to speak. Like it's, I think that they would have a very difficult time encouraging their child to be a doctor.
Wow. Well, if you don't become a doctor, then you won't be part of this podcast.
Well, they could be a friend. They could be the friend.
That's true.
The doctor and friends. Yeah. So
with the rise of AI too, right?
AI and then mid-levels, nurse practitioners, physician's assistants. It's medicine is a very changing field, and it's a very difficult field nowadays.
Well, before we end this, I actually completely forgot this. The president of Mexico has made healthcare available to to their people. What are your thoughts about that?
I hadn't heard that at all. So universal health care in Mexico now?
Yeah.
Like Canada?
Yeah, because they voted for a woman president. See what happens?
I had not heard about that at all and know nothing about that. But it has its pluses and minuses, the universal health care. So I'm of the mindset that, healthcare should be a given, that it shouldn't be a privilege, that if you're sick and you're in a bad way and you need help, that you should have access to medical care. So I definitely feel that way, but universal health care has a lot of negative effects as well and a lot of problems with it. So it's both a good thing and possibly a bad thing. But that's good for Mexico. I mean, I think I didn't even know what their health system was beforehand, to be honest with you. Right. But I know a shit ton of people who go to Mexico for all of their healthcare needs. So I think their doctors are well qualified. Their system is, a good system, and majority of people who go there, including I have several of my employees in the office who have gone to Mexico for plastic surgery.
Wow, yeah, I hear the same thing too. I have friends that are, they look to go to Mexico for that.
Yeah.
All right. Well, that concludes this episode.